couple of books for children because of what I learned from my own experience with my own daughters. And then those two handsome guys in the upper left corner, Larry Gifford and Tim Haig, and myself, we started the PD Avengers, which is a global advocacy organization, which works to increase collaboration and awareness in terms of advocacy, research, and wellness. We currently have close to 6,500 Avenger members in 93 countries across the world and 130 organizational partners. And the whole key there is to unite us as a global community and work together instead of working in silos. And so that is sort of my advocacy work now. Through my work in the PD Avengers, we started a working group on women in PD. And this came about basically because I had always heard anecdotally from friends in the PD community or women that I came across that there were differences in terms of how they were feeling on a monthly basis, or they were worried about how their Parkinson's would react if they got pregnant. And there were all sorts of women-specific questions that would come up. And it didn't really occur to me, that there were these differences, even though as a woman, I should have known. But we started exploring the research or what is out there in the field of research when it comes to women in PD. And what we noticed was that there was a real lack of good information for women and good practice guidelines for women to manage them at different points in their hormonal status. If you can go to the next slide. So what we did is a group of women, clinicians, researchers, some of us with PD, took our own personal experiences or what we had heard in the community to do deeper dive on what is really known about these differences. And we published this paper in 2022, The Unmet Needs of Women Living with Parkinson's Disease, Gaps and Controversies. And what do we know? What did we find out from the research that we had done? Well, we know that epidemiological studies have found that both the prevalence and the incidence of Parkinson's disease is lower in women compared to men. In fact, in the Global Burden Disease Study, which came out in 2016, so a few years ago, age-standardized prevalence of PD was 1.4 times higher in men compared to women. This ratio is reversed in Asia, where it's actually can be more common in women than men. We're not really sure why that is, but North American and European studies have shown it's more prevalent in men. And over the years, the incidence of Parkinson's disease has remained stable in women, where it has increased in men. We also know that the risk factors for developing Parkinson's disease are different as well. Caffeine consumption, which you may have heard, is related to a lower PD risk among men, but not women. Post-menopausal women actually have an increased risk of developing Parkinson's disease with caffeine consumption. Male smokers have a lower PD risk compared to women smokers. PD risk lowering effective alcohol consumption is more pronounced in women than in men. And then the whole estrogen story, which we'll talk about in a little bit more detail, but estrogen may have a neuroprotective role, that a higher total lifetime estrogen exposure may actually be associated with decreased risk of PD in women. But we'll talk more about that in a bit. Next slide, please. So this slide is from that paper, and it really highlights the differences between men and women, because those differences are not just in terms of risk, but they also in terms of what we experience as symptoms as women. The motor symptoms that women experience, we experience more tremor dominance as opposed to stiffness. We experience more facial masking, more dyskinesias, which I'm experiencing right now because I overshot my meds, and restless legs. And we have less disease progression, which I guess is a good thing. The non-motor symptoms, we're very prone to mood and sleep disturbances, which can be really detrimental to quality of life, with increased anxiety and depression, more fatigue. Not that we need any more fatigue with the way our lives are, but more fatigue, more depression, more urinary frequency and urgency, pain, meaning the chronic pain that you can get with Parkinson's. We do tend to have less cognitive impairment than the male counterparts, and take that as you will. But we also have less GI symptoms, constipation, swallowing difficulties, and less sexual dysfunction as well, although it still exists. What is different also for women with Parkinson's disease are the psychosocial issues that arise. We tend to, at diagnosis and follow-up, have more psychological distress, less health-related quality of life compared to our male counterparts at presentation, often have negative or destructive self-image or self-awareness, loss of femininity, impaired sexual intimacy. And these are things I'm going to discuss at a later time too, because they're really important in terms of quality. And we have less support, less psychosocial support as well. And we tend to present later and are diagnosed later compared to men, and offered things like DBS surgery later compared to men as well. Next slide, please. This is not to mention the actual hormonal life stage of a woman. When it comes to hormones and PD risk, there are conflicting studies, as I mentioned before. And this is very common in most areas of women in PD research. There's just conflicting information out there. For example, women with hysterectomy and on estrogen replacement only seem to have an increased risk of Parkinson's compared to women who go through natural menopause and are on estrogen and progestin. But then compared to another study that shows that going through natural menopause and being on HRT for hormone replacement for more than 5 years has increased Parkinson's risk. So it's really ambiguous in terms of what we know about or what we don't know about Parkinson's disease in women at all these stages of life. So if you look at the slide, we looked at hormonal status, meaning pre-menopausal, when women were having menstruation, and a lot of women will complain of their symptoms being worse a week prior or a week during their period, which means 2 out of 4 weeks they're not doing so well. The whole aspect of pregnancy needs to be studied better than we have. Perimenopause, what does this transitional period mean for your Parkinson's symptoms, and how can you manage that? And post-menopause, what about hormone replacement? What about the symptoms of menopause? How can we help women manage these symptoms so that we can actually improve quality of life for women? And that's really what this is all about. It's about improving quality of life as they look for a cure. Next slide, please. So the research, women don't participate in research as much as men, and that's a problem. But what do we need research in? We need to do research from the very beginning. We need to have animal models. We need to have women rats, female rats that they can test instead of just the male, so we can account for those sex hormonal interactions. We need interaction between, we need to research the interaction between sex and gender and Parkinson's risk, as we talked a little bit about environmental exposures and that sort of thing. We need to know about how women respond to hormone replacement based on their hormonal status. We need to look at is estrogen actually protective, and what is that effect in terms of exposure? Because some studies have shown that women who receive hormone replacement within the first 5 years of being in menopause do better. And then another study will say if you take it after 10 years of menopause, then it can be worse for your Parkinson's. So there's just so many questions that we just don't have answers to. And we also need to come up with really good guidelines that tell clinicians on how to manage women during their cycle, during menopause and perimenopause. Birth control pills, hormone replacement, all these things come into play at this point. And next slide, please. We have to also, as I mentioned, women don't participate in research as much as men. And this comes from a variety of reasons. We have to understand why women are not engaging in research and then develop those strategies that will help them to increase their participation. I think part of it is that we need to increase the healthcare providers' awareness to provide women. Women are just not offered research opportunities, studies have shown, as much as men. We have to understand that women sometimes have caregiver duties or home duties, as well as occupational duties or responsibilities. So we have to make it easier for women to participate, either online or coming to them sort of in community. We have to also recruit more women in clinical drug trials, because a lot of what we do now in terms of treatment has all been tested on men and not women. So things like drugs are given in the same dosage to women compared to men, yet we know that metabolism of drugs or medications is not the same in both genders. So that's really important to look at. So what I've talked a lot about what we don't know, and unfortunately that is going to be the theme of tonight. We don't know a lot, unfortunately. Next slide. This is a group of women through the PD Avengers. This is part of our working group on women in PD. And we got together to say, okay, we're tired of not knowing enough about this subject. So what can we do? And next slide, please. We got together and as part of this working group, and we basically partnered with the Fox Foundation to create and disseminate a series of questionnaires. And some of you hopefully may have known about this if you're part of Fox Insight and have contributed to the research. That I hope so. That would be great if you had known about it. The first survey went out in May of last year, and it was experiences of women living with PD, female health and home life. We had over 3,000 responses to that, and we're in the middle of compiling the data. But I will show you one graph in the next slide. And the second survey, experiences of women living with PD, pre, peri, and post-menopause, has close to 2,500 respondents so far. That survey is still open, and that is looking at how women experience Parkinson's disease and how Parkinson's disease affects women and their treatment at various hormonal stages of life. Next slide, please. And this is one of the pieces of information that we got. It's going to be a huge data set of information that researchers can access. But this is one I thought was interesting for you to know. So from our first survey, we looked at self-image in women. And I guess self-esteem can be defined sort of as an overall sense of value or worth. And it's when you have poor self-image or self-esteem, it's your concept of self-image is a result of internalizing of negative stereotypes. And this can be influenced by genetics, age, life experience, socioeconomic status, health. In the case of PD, those traits that are externally visible, as you can see, the tremor, excessive saliva and drooling, gait disturbances, dyskinesia, freezing, facial masking, they can all be particularly impactful as visibility may result in perceived or real external judgment. And our data confirmed that these impact women quite significantly, as you can see from the graph. Next slide. So that's just a brief introduction into this sort of massive subject of women and Parkinson's disease and what we know or what we don't know, and why it's so important for us to know, because it all boils down to the quality of life for women living with this disease. And we're a significant number of women, millions and millions of women across the world that are really not being optimized in terms of their level of quality of care that they could be, should we not know, or should we know more about this disease and how it manifests in women.
Thank you, Sonia. I think that raises lots of questions, as you say, that there's so much more exploration required, and different ways of researching that's going to be required to answer some of those questions. So to begin the questions from the floor that have been sent in, we'll start that process now. And there's a question that is raised that is talking about differentiating between Parkinson's and menopause, that many of the non-motor symptoms of Parkinson's are the same or similar to those of menopause. And this person initially thought she was experiencing delayed menopause symptoms. How can we differentiate between the two better? And specifically, what can women with Parkinson's do to improve things if they experience reduced sexual sensitivity, presumably as a result of both menopause and reduced neuron function, neuron death? So it's a big question.
Yeah, it's a big question, and it's a difficult one, unfortunately, to answer, because she's very right. It's true. It's very difficult to differentiate between the two, given the similarities. I mean, there's temperature dysregulation in Parkinson's disease, and there's hot flashes and excessive sweating in menopause as well. Mood changes, reduced libido can be in both situations. So it's very, very difficult to differentiate based on just a snapshot. You look at it more in terms of the whole person. When did these symptoms arise? Was it in line with when your period stopped and you were going through menopause or perimenopause? So it's more the timing that we look at. Are those symptoms improved with hormone replacement, if you were to try that, or are they not responsive to hormone replacement, which would be more in line with Parkinson's symptoms? Fatigue can be the same in both. So it's very difficult to differentiate between the two, but you have to look both at the timing of the manifestation of those symptoms, or the occurrence of those symptoms, as well as the response to treatments as well. But regardless, you know, the whole thing is affecting quality of life, and needs to be treated one way or another. Particularly, and we can talk about sexual intimacy now or at a later time, but that's a very important and a bit complicated topic of conversation as well.
Yeah, and just as a Parkinson's nurse in New Zealand, we don't often ask those questions of women in our assessment.
Yeah.
And people don't readily volunteer them either. So maybe we need to do more.
I think so. I agree. And as physicians, we don't ask those questions either. And that's maybe because of two reasons. One, a lot of clinicians may not even be aware of that issue. And the second thing is, so even if they're aware of it, it doesn't necessarily come to mind as being something that is significant. Whereas we all know that, you know, sexual intimacy can affect relationships. Relationships can affect your quality of life in general. So the lack of understanding of the significance of these issues is something that's pervasive throughout the medical community.
Yeah, and it's very sensitive personal information, and we do ask in general stuff about that, but not, you know, people very rarely volunteer it.
Yes, that's true.
Yeah. So the second question is about HRT, which you've touched on a little bit. So
Mhm.
is HRT beneficial for postmenopausal women with Parkinson's disease, particularly in regard to sleep quality, which I think you touched on as well, duration, restless leg syndrome, and REM sleep behavior disorder?
Again, we don't know the answer to that question necessarily because it hasn't really been studied. I mean, hormone replacement is really good at helping out with treating vasomotor disorders, or which are things like your hot flashes, for instance. They're helpful in terms of physical things like skin and can be beneficial for mood and energy level and those sorts of things. And bone health obviously is another thing it's helpful with. But in terms of how it affects Parkinson's symptoms specifically, I don't know that we know yet. I mean, I think it's changing now. We're using more hormone replacement in postmenopause than we were, say, a few decades ago, because it's generally thought to be fairly safe if it's used within the first 10 years of menopause, obviously taking into consideration individual risks. But in terms of whether HRT is specifically linked to an improvement in quality of life for women and takes care of those symptoms that you mentioned, it's hard to say. I will say sleep quality, from what I understand, is improved with hormone replacement, but that can be in general, not necessarily specific to Parkinson's disease.
Yeah, and that's a big one for most women
Mm-hmm.
during menopause, you know.
Yes.
Yeah.
Oh, I know.
The other question is HRT more widely used and more acceptable today compared to 30 years ago in regards to the cancer risk?
Yes, I think it's considered pretty safe in terms of either cancer risk or thromboembolism, which are blood clots, if you take into consideration individual risk. There's breast cancer, for instance, is the same as if a woman had prolonged exposure of her own hormones, meaning that if you had an early start to your period and a late menopause, that lifetime exposure to estrogen would be a risk factor for developing breast cancer, the same as if you were taking HRT. So it's the duration of estrogen exposure, not necessarily the source of estrogen. So that cancer risk is really not too much to worry about with HRT these days, as long as there isn't any, active cancer that the woman has at the time that she starts the hormones. So medical professionals are using it much more frequently now compared to back in 20, 30 years ago.
Yeah, I think you've answered the next question, so I'll just read it out, but I think you've actually answered it. What are the side effects of HRT, and do the benefits outweigh the risks? What are the benefits? So I think you've kind of touched on
Yeah,
that.
I mean, there are other side effects like breakthrough or irregular bleeding for the first 3 to 6 months, breast tenderness, nausea, headache, bloating, the risk of blood clots, which again increases over the age of 50, is more related to if you're a smoker or obese or sedentary. Stroke is another potential risk factor, but that is usually over the age of 60 and increases with age. And again, it's a potential risk, but usually, depending on your individual risk status, it doesn't outweigh the benefits usually. Migraine is another potential side effect. So there are lots of anything you take, there's side effects or risks, and it all has to be individualized in terms of what you end up doing in terms of treatment.
Yeah. So this next person says, I get a lot of muscle pain and stiffness first thing in the morning, which I think is not unusual in Parkinson's. It's one of those things that can happen. After sitting and worsens with exercise. Would HRT help with the muscle pain, regardless of whether the root cause is from Parkinson's disease or menopause?
I'm not sure what the answer to that would be. I think there's a lot of contributing factors to that sort of muscle stiffness first and muscle pain first thing in the morning. Certainly Parkinson's disease at any stage of life can cause that, as you mentioned. I think with advancing age, that can also be a factor, regardless of your Parkinson's status or your hormonal status. With time and with wear and tear that we have in our bodies, that can obviously contribute to those symptoms. I think I wouldn't necessarily use HRT to treat something like that. I would look at more lifestyle things that you could do in terms of the types of exercise. I know that you mentioned that the person that asked the questions that said it got worse with exercise, but maybe look at the type of exercise that you're doing. Yoga is very, very good in terms of loosening up your body and your joints and your muscles. It's very helpful in terms of reducing the pain that you get from the contraction or the contracture that happens to our muscles with Parkinson's. I mean, this is a disease that makes us tighter and smaller, and yoga helps to counteract that. Weights as well. So increasing your muscle mass is actually very helpful in terms of the stiffness and pain that you feel. It may sound counterintuitive and it may hurt while you're doing it, but ultimately the results are better.
Thank you. So we're going to change tack a little bit here and go on to menstruation. So this person is 41. My motor symptoms started at 38 when my baby was 6 months old. I was diagnosed at 39 and have been on levodopa for nearly 2 years. Occasionally, I feel overwhelmed with frustration when I'm with my little girl, who's now 3.5 years old. I feel like I'm going to completely snap with anger. It's really out of character for me. I feel scared by it, and as if I'm not in control, almost like I'm a different person. The last 2 times this has happened have been at the start of menstruation, and I'm wondering if it might be more hormonal plus Parkinson's, and whether you've heard of this experience or had experience with anyone else with it similar.
Yeah, that's a tough position to be in, because you can tell from the way she's written it that it's really distressing her, that she feels that a level of concern when it comes to her little one. Have I heard of this? Yes, of course. I've heard that, women at the start of their menstruation, as I mentioned, or the week before their menstruation, when their hormones are fluctuating, can have this kind of variation in mood and this sort of up and down ebb. What I would say, first of all, is it's important to address this. This actually could be a medical thing. So it's important to bring this to the attention of your medical team or your movement disorder specialist. The reason being is that depression and anxiety are very common in Parkinson's disease, particularly as we went through the information before, particularly in women. And so that being so common, I would recommend that they see their physician to get screened for depression or anxiety, because that can also then lead to difficulty coping with certain situations, which again, it can be made worse by hormonal changes during the month. So even if you're depressed or anxious at a low level, it can be aggravated by changes in hormonal status that you would see prior to menstruation. So I think that's a really important thing to look at. I wish there was some way of saying that, if you go on the birth control pill, this will help, or if you take this medication, it will help. We, again, just don't know what would help in this situation. But the screening for depression and anxiety, I think, is a really key thing. And also the psychological effect of this disease. This disease is not an easy one. It affects us emotionally, mentally, physically, spiritually. It affects us socially. It affects our relationships. And we can't minimize the impact that it can have on anyone's life. But, particularly as a parent, when it comes to parenting, that's a whole area of discussion, which we can certainly get into if wanted. But you need to surround yourself with a sort of a group of supportive individuals, or a community of supportive individuals that can help you manage the challenges that this will bring into your parenting life. So you have to look at it from that angle as well.
Thank you, Sonia. Yeah, it's a very difficult situation for young mothers anyway, and women always trying to do their best for their children worry when things go awry. And
Right.
it's really important for people to have support, good people they can talk to and share.
Yes.
So,
yeah.
And also feel confident enough to talk to your GP about
Right. And there's lots of women. I mean, this woman is not alone. There's many of us in the community that she could reach out to, that have gone through similar things. I mean, like I showed you, I was pregnant with my first child when I was diagnosed, and I had 2 more after that. Now my kids are 24, 22, and 18. So, my experiences may be helpful to someone who's starting off on this journey in the first place. And there's lots of women online support groups that you can access that might be helpful. We learn best from each other.
Yeah, thank you. The next question relates to menstruation as well, and issues around magnesium levels. So I'll just read the question. I've read that in the 7 days before menstruation, the body's magnesium levels are at their lowest and inflammation at its highest. Is this true? And if so, do you have any comment about this in relation to Parkinson's, whether it might be a culprit in increasing pain and muscle stiffness? For example, any recommendations for improving and managing this, as well as supplements and diet? So this is a very broad question with some specifics in there.
Yeah. In terms of nutrition in Parkinson's disease is a very large topic. And thus far, we really haven't had any specific guidelines in terms of supplements, for instance, to be taken for Parkinson's disease. A lot of the studies that have gone into looking at things, supplements, have not really yielded concrete results in terms of recommendations. We talk a lot about the Mediterranean diet being a good thing, and heart healthy fats, as well as increasing your vegetable fruit consumption, the lack of need for a multivitamin if you're able to do that, taking calcium for women in particular, postmenopausal, and vitamin D, because Parkinson's disease itself can lead to bone issues. Magnesium is sort of a popular thing right now in all areas of health, and magnesium levels can fluctuate. I'm not sure if it's low at that particular point that she's describing, but they certainly can fluctuate. And if you're not getting magnesium in your diet, then you could always try a magnesium supplement. It's also supposed to be good for sleep, which again is a very common issue in people with Parkinson's disease. But yeah, there's no firm guidelines when it comes to magnesium in Parkinson's.
Yeah, in New Zealand, we often support people taking either magnesium supplements or having the rub-on formulations that help with muscle stiffness. The oils impregnated with, and So people find a lot of comfort from those, and I don't know whether this person knows about those. So, yeah, so they all help, and they also tend to relax muscles and increase the ability to get to sleep, which can be an issue sometimes. So the next question is completely different. What can be done to stop drooling? And this
drooling.
is,
Go ahead.
No, you go.
Oh, I was going to say drooling is a really difficult symptom to experience, because it really has an impact on your self-image and your self-esteem a lot of times, especially that's one of the symptoms that women said was particularly bothersome when it came to their self-image. And it is, it is fairly common, starts off usually at nighttime and then can occur during the day. It's usually not necessarily the production of more saliva, but the lack of swallowing of what saliva is there. And also your mouth can be held open involuntarily as Parkinson's disease advances. And so drooling is a definite symptom that is really difficult for people to experience. How do you manage drooling? Well, the first thing would be, if you're drooling, you need to see a speech language pathologist who can assess your swallowing, because oftentimes drooling and difficulty swallowing can go hand in hand. And if you have dysphagia or difficulty swallowing, then that can lead to things like aspiration and pneumonia, and you're not protecting your airway when you don't when you eat, for example. So you do need an assessment by a speech language pathologist who can perform a swallow test and diagnose any of the difficulties, and also give you some strategies. They're good at providing strategies to help with drooling. There are things like sucking on a hard candy or chewing gum, and that sometimes causes you to have an automatic swallowing reflex and clear the saliva. You can there are some medications also that can, if those sort of things don't work, if you're still having difficulty with drooling despite chewing on hard candy or making an active concerted effort to swallow or that sort of thing, there are some oral anticholinergic medications. There's the scopolamine patch. There's some there's treatment with Botox, for instance, that could also be helpful for drooling. So there are management ways to manage this symptom of the disease, and it's unfortunately a very bothersome one.
Yeah, and looking at your graph of the self-image issues that affect people, that was high, and it also related to facial masking and things like that. Yes. And here we encourage a lot of facial exercises and singing and things like that that help move the muscles of the mouth and the face to help strengthen those muscles, which we don't do a lot of, but it does seem to have an effect as well. So yeah, so a lot of my clients chew on gum. And it's not something we do a lot in New Zealand. So, yeah, but it does help the swallowing. The next question's about what can be done for incontinence, and that's a huge question because of the propensity for frequency and urgency that can come about as a female.
Yes. Yes, it's a very significant symptom, and can range from just having to go to the bathroom more often to actual incontinence. And again, one of those non-motor symptoms that really affect quality of life for patients. So there's some lifestyle things that you can do in terms of reducing your fluid intake prior to going out, for instance, going to void at set times, so schedule voiding so that you don't extend your bladder, for instance. Making sure you're close to a bathroom when you do go out, wearing pads or absorbent underwear in case you do have a leak and that sort of thing. And then there are medications. Now, the older medications that we used for urgency, urinary urgency, because that's usually what it is in Parkinson's disease, as opposed to stress incontinence, which happens otherwise. Urinary urgency or urgent continence is usually the bladder kind of goes into spasm, and you have no control over it sort of compressing down and expelling the urine. So the medications that we used to use were actually not great because they would cause side effects of potential falls, for instance, and dizziness and sometimes cognitive issues as well. But the newer generation of urinary urgency medications is quite good. And I'll share with you personally, I take one now and I have no issues with feeling like I'm going to lose control. And so it's been actually a great help for my own quality of life. I no longer have to time everything and, make sure I scout out where the bathrooms are as well. So there are some new medications which you can talk to your physician about that will really help, and they don't interfere with the medications that we take for Parkinson's disease.
Thank you, Sonia. Okay, so this lady, the next lady, is concerned about sex, little or no enthusiasm for it, and how can that be addressed?
Right. Well, I mean, sexual functioning is a complex process. It's dependent on motor, sensory, autonomic systems, our hormones, vascular or blood and neurological systems. It requires blood flow to the genitals. It requires balanced hormones. It requires a healthy emotional state. It can be influenced by psychosocial factors, family, relationship issues, self-esteem, self-imaging, aging, and various illnesses and treatments. In women with Parkinson's disease, it's often not necessarily a pleasant experience with the vaginal tightness, loss of lubrication, sometimes involuntary urination, anxiety can also play a role in inhibition. And that muscle tightness and the slowness and the lack of motor control, the clumsiness that sometimes happens when we're in an off state, sweating, the drooling, as we mentioned before, they can often be disconcerting. The tremor and dyskinesia can be worse during sexual arousal. So these are all issues that occur with women in Parkinson's disease. And it's, as you mentioned, not addressed enough by a movement disorder specialist or your medical team, either out of lack of knowledge or just not thinking it's an important thing. But as we discussed, it's an important for your quality of life in terms of your relationships. The not interested in sex, meaning lack of libido, is again also a postmenopausal issue as well. So sometimes if you are placed on hormone replacement, that can help with lack of libido. And then also working with a counselor can sometimes be helpful, especially if a woman is affected with self-image issues and feeling less feminine and less desirable because of her symptoms. I think that can sometimes be very helpful to speak with somebody about those issues. If not your physician, then a counselor can be very helpful in that way. Working with your partner to sort of be open and discuss these issues, I think is really important as well, because they may not be aware of your fears or your concerns or the way you're fearful of how they're perceiving you. I think these discussions need to happen as well with your partner so that you can come up with times that are best for you. Sometimes evenings are not good because a lot of people are off during the evening time. Maybe daytime is better for you as a couple to experience that sexual intimacy. So it's a very complicated process, and it depends really on the individual and what they're experiencing and how their Parkinson's is affecting their sexual intimacy. But I think the overarching thing is to remember that it is an important part of management of Parkinson's disease, and there are resources out there that can help depending on where the difficulty is.
Thank you. It's such a sensitive issue and so personal. This next question is a very interesting one, about grooming and dressing and being a woman and self-esteem, essentially. So is there a resource somewhere with ideas on how to cope with dressing and grooming? Obviously, there's some difficulties sometimes with that, with some of the symptoms. And I'm thinking hairstyles, jewelry, undergarments, makeup. These are all part of who we are and who we still want to feel, as though we're still ourselves. So often just applying makeup or managing certain garments and clothing can be quite difficult. So I think this is what this person's relating to. This question.
Yes. Yeah, it's an excellent question, and it's spot on. I mean, when this disease takes these seemingly minor things away from us, it actually is not minor. It can majorly affect your self-image and your self-esteem. To not be able to, say, wear those stiletto heels that you like to wear, or get into your a tight sweater that you like to have on, or your makeup, you can't do your makeup anymore. And I think that some of that I've experienced myself, and I've had to basically reevaluate how I do things and how I approach things. So, for example, I've got 3 girls that love to do my makeup. And so if I have to go anywhere special or where I can't look like I've smudged everything on, I use them as a resource. For example, there are some, there is a company, and the name just doesn't come to mind, that actually has Parkinson's specific makeup application with the applicators are easier to handle. I can get you that resource. Changing the way you wear your shoes, for instance, they're now hands-free shoes that you can just slip on, as opposed to having to bend over and tie laces or put them on with a shoehorn. They can just slip your foot in. But these are very good questions, and I think it's important to try and find ways to work around some of the limitations that you have, so that you do. It's important to feel good, and it's important, if that is part of looking good for you, then I think it's important to maintain. We don't need to necessarily succumb to everything that this disease takes away from us. And stay tuned, because that's actually a resource I'm working on, is trying to give women resources and tips and tricks on how to maintain their the way they dress and the way they feel and their makeup, and because they seem like superficial things, but they're not. They're really integral to the way you feel about yourself and your self-esteem and self-image. So I will be starting actually that. I've already started that project now, so stay tuned for that.
We'll look forward for that, Sonia. But if you can flick us the company resource, that would be great for the makeup. That would be wonderful. Thank you. And I'm sure this person would really appreciate that if it's possible.
Yes, absolutely.
Okay. So I think that's the end of the actual audience questions, but I have a few others that here that we had from Parkinson's New Zealand. So if you're happy to just quickly work through those, we'll do that.
Mm-hmm.
Is there a reason why women have a lower risk of getting Parkinson's than men?
Again, we talked briefly about this, but we think that estrogen might be neuroprotective.
Yeah.
And it would be the total lifetime exposure of estrogen in Parkinson's that might lower your risk of developing Parkinson's disease in women. But that's the going theory, but we're not sure. It has to be studied a little bit more.
Yeah, so there's some advantages of being a woman.
And it's an important thing, because that not only will affect women, but it'll affect men. Because if we can figure out why estrogen is protective for women, then that gives us an increased understanding of the disease in general, which helps the entire community, regardless if you're a man or a woman.
That's great. You've outlined the second question, one of the symptom differences between men and women. You've already done a slide on that, so I won't do that. The next one you've already answered as well, about neuroprotection of estrogen. So that's, you've just talked about that. Why do women appear to suffer more dyskinesias than men? Is there a reason that we know about?
Yeah, it goes back to what I was saying about treatment development being done for men, specifically in terms of dosage. We're smaller in terms of body mass compared to men. So a dose of Unmet for a man compared to myself would be very different in terms of its effect. And the side effect of dyskinesia would be much more likely to occur in a woman because of lower body mass, and also decreased or differences in drug metabolism or breaking down of the drug as well. So because we have a different metabolism and we have a different body mass, that often leads to more dyskinesias in women compared to men.
Thank you. I think you've covered some of what research is there in regarding women and Parkinson's. So we might, unless you want to particularly address that.
Well, just to say that the surveys that we've done are in a database called FoxDen through the Michael J. Fox Foundation, and all researchers have access to that information. So the database will serve to hopefully inspire more research into the whole field of women in PD, because they have access to the data that we've collected so far.
Thank you. And mental health, are there greater implications for women regarding their mental health, particularly as women have multiple roles within a household as a primary caregiver for children and managing sometimes jobs and other things that they do? So is there more implications in terms of that?
Yes, I think there is. I think there's a lot of psychosocial stressors that affect women compared to men. I mean, not all men, of course, and I don't like generalizations, but in general, there are more psychosocial stressors. Women don't have as much time for self-care because of their caregiver duties, either to children or to aging parents and that sort of thing. Women are more likely to say they're stressed about their life situation. They experience more stress compared to men. They're less likely to get outside help compared to men for care. And they're more likely to end up in a assisted living situation compared to men, because they don't have the support at home.
Right. That's an interesting concept, isn't it? That part. So the last bit is more around pregnancy and research. So does pregnancy have an effect on PD symptoms? And you've been a mother 3 times, so you'll have some personal experience of that. And are the PD medications safe in pregnancy, and can you breastfeed with those?
Right. Pregnancy is actually our next survey that's coming out. It's very important. And I speak to a lot of women about this, given my personal experience with being pregnant, delivering 3 times. Each experience was highly different. The first one was very nonchalant. I just delivered the baby and that was it. The second one, everyone was in the room because they all of a sudden were worried because they didn't know what to expect with Parkinson's disease and pregnancy. And the third one was back to just no one being in the room except myself and my physician. So it was basically no guidelines is what I'm trying to say. There's no guidelines for treating women who are pregnant and have Parkinson's disease, because Parkinson's presents before the age of 40, about 5% of cases. So it makes pregnancy post-diagnosis fairly uncommon, I guess, and that's maybe why it isn't focused on as well. So there's no consensus to guide physicians or patients. In terms of what the studies have shown us, the reports are conflicting, but with some women report that their Parkinson's symptoms were stable, and some, about 50%, reported that their condition worsened during pregnancy. And although many returned to their expected baseline after they gave birth, others reported a deterioration in their condition that did not improve, a few. And some of these negative effects may be due to the fact that women choose to hold their medications during pregnancy, or because the metabolism of the drugs changed during this time. Personally, I felt that my symptoms were worse during my pregnancies, but usually returned to baseline once I gave birth. But again, this could have been a medication effect because I wasn't taking much of my medication. In terms of what's safe, again, you can't ethically test medication in pregnant women, but amantadine is known to be teratogenic. It's not safe to take during pregnancy. That's one thing we know. We think that Unmet or dopamine replacement, is likely safe during pregnancy. But again, those risks have to be taken into consideration with your medical team, really. Personally, for my first pregnancy, I was early in my disease course. I didn't take any medication at that time. My second one, I waited the first trimester and then took some Unmet to help my symptoms for the second and third trimester, and the same with my third. But again, it's very dependent on how you're feeling, what treatment you're on. But the one I would say is amantadine, but should not be taken when pregnant or breastfeeding.
Yeah. And I think the issue of more and more women being diagnosed with early onset and possibly in child bearing age
Yes.
is going to increase. It seems to be increasing. Is that correct?
I don't know if we have the demographics to say that, but I think as the overall population and the numbers grow, then that group of individuals or that segment will grow as well. So that's a fair statement.
Yeah. Okay.
Mm-hmm.
Well, I think we kind of.
The good thing is that we know that Parkinson's disease does not affect pregnancy per se. It doesn't affect the delivery process per se, and it doesn't affect the health of the baby. So those are things we do know.
And those are really important things for young women to know if they suddenly become diagnosed, and in that situation, it's reassuring.
Yes, yes.
So I think we've come to the end, and I haven't had any hands up for anything. Are you there? Oh, Andrew's popped up. Do you want to say something to finish, Andrew? You're not on.
I think I'd have that right by now after so many years of Zoom. But say, Sonia, just to say thank you so much. It's been a very, I have to say, distressing for me to listen, because I know how hard it is for me already. And to think that women have a whole nother drama to deal with, that we glide through without knowing. It just is distressing to hear. So thank you for bringing this to our attention, and for the work that you do. You are a trailblazer, and the world needs trailblazers. So thank you for you putting yourself on the line, and making yourself vulnerable and sharing deeply personal parts of your story, so that others can learn and be encouraged and do better. So thank you for your contribution globally and today.
Thank you for the opportunity. I really appreciate it. And anyone that's listening, if they need more information, they can find it on my website, or they can also get in touch with me through my website. I'd be happy to help out.
You're very generous. Thank you. Thank you,
you.
Glenys, for hosting us, and thank you everyone for your participation. And look forward to a webinar in the near future. We'll get the ads out when it's been arranged.
Lovely.
Thank you, Sonia. Thank you so
Thanks,
much. Thank
Sonia.
you, everyone.
Take care. Bye.